Our next speaker is Dr. Michael Tuttle. He's going to be talking about perioperative risk stratification in thyroid cancer. Michael Tuttle, an endocrinologist, professor of medicine at Cornell University, and chief of the endocrinology service at Memorial Sloan Kettering Center in New York. Mike designed and validated the first real-time risk assessment model for thyroid cancer management, in which individual risk estimates are modified over time as a function of response to initial therapy. In addition, his clinical studies have helped to define the role of recombinant human TSH as an adjunctive for radioactive iodine therapy in both low-risk and high-risk patients, and in the setting of radioactive iodine avid distant metastasis. His research continues to center on important management aspects of thyroid cancer, including efforts to better define risk of recurrence, risk of death, and the potential role for observation in low-risk thyroid cancer. His clinical practice is entirely devoted to patients with thyroid cancer, with a particular emphasis on cases with aggressive disease and complicated management issues. Mike, welcome.
Fantastic, Seiza. Thank you very much, and thanks to the organizers. It's always amazing to listen to Dr. Fagan's talk and sit and think about how much the description of those molecular biology changes are actually we're using in clinic. You sit in clinic with us now, and my clinical doctors talk about RAS tumors and BRAF tumors and BRAF and TERT, not only for prognosis and risk stratification, but also, as Jim mentioned, what's the likelihood of responding to therapy? And we'll come back to that at the end of the talk. It's amazing to sort of think, I picked 1990. That's when I started my thyroid cancer endocrine fellowship when I was still in the Army. And if I think about risk stratification back then, risk stratification was really all about the risk of dying from thyroid cancer. Most of people would use MESIS or sometimes AJCC, but those were really single time point estimates. They never changed. You were whatever stage if you were 30 years later. As an endocrinologist, they were unsatisfying because they didn't predict the risk of recurrence. They really provided no preoperative risk assessments because it was a one-size-fits-all before surgery. And what that meant is for an individual patient, this single time point risk estimate really wasn't very helpful to me clinically. Now, if I fast forward, sad to say 30 years, doesn't seem like that long, and think about how we're thinking about risk stratification in thyroid cancer now, we really see it as a dynamic, iterative, active process. It's not a single time point. It doesn't start after surgery. We are now thinking about risk stratification all the way back when we see a suspicious nodule, when we make decisions about surgery. And then, of course, after surgery, we want to know what's the risk of death and what's the risk of recurrence. And then probably even more importantly, what's the risk? How does that change over time? As we follow people along, sure, you were high risk to begin with, but maybe you're doing great. You responded great to therapy. The biology of your tumor is very favorable. How do we change our follow-up based on those response to therapy sort of findings? So if we look at this paradiagnostic risk assessment, and this is a word that I stole from the pulmonary literature, because the pulmonary doctors have to deal with small nodules in the lungs all the time. And they got to decide, do we biopsy? Do we watch? The same decision making we're making in small thyroid nodules. And they had described that as peridiagnostic risk assessment. And that seemed good. So we brought that over into our language. And we began to ask questions like, is an FNA really necessary? If my dad has a 5 millimeter highly suspicious nodule at 85 years old, are we doing him a favor by making a biopsy and making a diagnosis? You've just labeled him as a cancer patient at 85 for a disease that's unlikely to hurt him. So we have to ask questions, is that a good idea? Is immediate surgery necessary? In the old days, every cancer had to be treated. But now we understand that's not always the case. And now, even more importantly, since we're finding low-risk thyroid cancer, what's the right surgery? Is it a total thyroidectomy? Is it a lobectomy? And what we're really asking in this peri-diagnostic period is the patient a candidate for minimalistic management? And by minimalistic management, we mean maybe observation without a biopsy, maybe observation with a biopsy, maybe a lobectomy, maybe total thyroidectomy with no radioactive iodine, because there are clearly patients that need to be treated. We don't want the pendulum to swing so far we treat this as a benign disease. And obviously, every 4-centimeter thyroid cancer was 5 millimeters at one point. So we don't want to ignore all of those. And so with JP Brito, who's now at the Mayo Clinic, was one of our thyroid cancer fellows, we first began to think about this in the evaluation of people for active surveillance. Who were the patients that we thought would be good to follow with no surgery to begin with, building on the huge experience of Dr. Miyauchi and the team in Japan. And when we began to look at sort of the first 50 patients that we'd had this discussion with, we realized that there were really 3 sort of domains we were thinking about. Yes, they were generally papillary microcarcinoma, but what about the ultrasound characteristics, lymph nodes, size, location? What about the medical team characteristics? And what about the patient characteristics? And to make a decision for a patient, we were actually thinking through all 3 of those. And so for us, the tumor and nodule characteristics is less than 1.5 centimeters or so, highly suspicious, will follow the BRAF V600Es as long as they're that low risk confined to the thyroid. We're fine with some background abnormalities if the patients will accept that. We don't want to follow ones that are definitely getting bigger or lymph node metastasis. So all of these are ones that would make us worry. Now, the one thing that I will point out is the Japanese, and we have always said, be careful with these subcapsular locations because the ideal patient has a thyroid cancer with lots of normal tissue around. If this grows a little bit, no big deal. These take a year or 2 to grow, we'll be able to treat it. Many of these sit right up against the capsule. And so if you have a good ultrasonographer to make sure it's not invading through the capsule, it's not ideal, but we would call that appropriate. Same way here, if it's just touching the capsule or there's normal tissue, but if it looks like there's a long face or it's on the capsule near where these recurrent laryngeal nerves run, well, even in a small tumor, that's probably not a great one to watch. Now, as we began to explore how do we sort of export this outside the ivory tower on the Upper East Side of Manhattan, it was clear that the medical team characteristics were going to be an important part of this. Ultrasonographers were important. Do you have good ultrasonographers? Do they know what lymph node metastasis look like? I can't just take an ultrasound report that says a 9 millimeter nodule. I need 3 dimensions. I need to know the location next to the capsule, near the nerve. So all of that is important because even if the tumor was ideal, if you don't have an appropriate medical team to follow that, that's not going to be very helpful to us. And then the interesting part that we don't have a long time to talk about today is the patient characteristics. There's no doubt that patients that seek out care from me obviously want to watch. They know I'm not a surgeon. They know I'm likely to watch these things. So I get to see a bunch of patients that are really motivated to keep their thyroid, either because they don't want to be on thyroid hormone pills or they have just rejected our treatment options. I used to call these patients observation patients. I don't anymore. I call these patients self-therapy patients. These guys are all doing things to try to treat their cancer. And I found this out because I would come in the room 6 months later and I would say, good news, it didn't get bigger. And I would get this disappointed look that said, well, it didn't shrink, it didn't get smaller. And in fact, they were doing every herb I've never heard of, diet, they do something called exercise, all things I'm unfamiliar with, but trying to treat themselves as part of this process. So what we ended up doing was saying, look, we need some words to kind of describe this peri-diagnostic period. And so we came up with these 3 words. The patient, you could take all of these factors and the patient would either be ideal, appropriate, or inappropriate. And it turns out this sort of triangle works about right. There are a few patients that are ideal, but that's not most of them. There are a few that are inappropriate, also not most of them. And then most of them are what we consider appropriate and that we can follow with observation. And that's how we select them. Now, as we began to think about this, the ATA guidelines came out and said, well, hey, we can rethink about lobectomy again. This is the argument that won't die. It was the substance of every thyroid meeting in the 1970s, and it's the full circle, and we're back to having that same argument. But if we take this same approach, can we look at these three characteristics that we're seeing here and then classify people as ideal or appropriate for a lobectomy? Now, if you think about it, it's a little more challenging because there are two additional data points. So I can go through the first three boxes, tumor, medical team, and patient, and say, yeah, you look like an appropriate patient for observation, or you look like an appropriate patient for lobectomy. But I'm not really going to know whether they're appropriate until after we know the intraoperative findings, and in fact, after we know the path report a couple weeks after surgery. So when patients are selecting this lobectomy option, I try to explain to them, I can probably classify you as appropriate for lobectomy, but you have to be comfortable that there may be some intraoperative findings where the surgeon would make the decision to do a total thyroidectomy instead of lobectomy, or there may be some findings on the path report that would say, you know, maybe you need radioactive iodine, maybe we need to go back and do a completion thyroidectomy. If you look at the rates in the literature, the completion rate runs anywhere between 60 and 20%. The differences are largely built on the endocrinologist's desire to do radioactive iodine. The 6% at Memorial, we don't often do radioactive iodine for these borderline cases, the ones like Jim was talking about. Other groups have a lower threshold to do radioactive iodine, so it may be 20%. But what's been very clear in the literature is even if you need a completion thyroidectomy or years later you need a delayed completion thyroidectomy, overall survival is the same, and these patients do very, very well. But if they're going to choose a lobectomy, they have to understand this entire rainbow so that the intraoperative findings, the path report, and the need for completion thyroidectomy, and based on some patient characteristics, they don't find that acceptable. We've all had patients that say, look, doc, you're going to put me to sleep one time. That's it. Do everything you need to do. And other people tend to be more minimalistic. Now, if we move to sort of the second piece, which is once we've sort of figured out what we think their risk stratification is before surgery, and in fact, if they need surgery, that takes us to sort of how do we then take all of that preoperative and intraoperative, and in fact, all the information you get in the first 4 months after surgery to do the 8th edition. We gave you 4 months after surgery so that if people need CT scans because of an elevated thyroid globulin post-op, or you need a radioactive iodine scan, all of that information can be incorporated into your 8th edition staging. So it's preoperative, intraoperative, and up to 4 months post-operative. Now, if I'm honest with you, I never really used the 8th edition system, the 7th edition system, because I didn't find it very helpful to me. There was too much overlap between stage 1 and 2 and 3, and I complained so much about it. They finally asked me to do something about it, and so with Nancy Perrier and Brian Haugen, Lila Morris, Jayton Shaw, really a wonderful group of patients, doctors, we said, let's relook at this 7th edition and make some changes. In the old 7th edition and before, there was a magic age 45 cutoff. We moved that up to age 55 based on a lot of published data. In the older patients, in the old system, even minor extrathyroid extension on a microscope made you stage 3. A teeny tiny lymph node metastasis in the central neck made you stage 3. God forbid it was in the upper mediastinum, it made you stage 4. None of that made sense. Now, it made sense in the old days when that referred to gross extrathyroid extension and big volume lymph node metastasis, but not where we are now. And so the idea is that if we redid how we did the classification, many people would be reclassified into lower stages, which would be appropriate, and that we would get a better separation. If you look at what the staging system looks like now, rather than doing T1, N1, whatever, that always was too hard for me to think about. There's really sort of 3 factors that you need to know. And if you think about the last several patients you saw with thyroid cancer, I can show you in this corner, you can stage the vast majority of them. Age at diagnosis, I used to refer to this as older and younger. I don't anymore since I've passed this number. But if you're less 55 years old, you're either stage 1 or stage 2. If you've got distant mets, you're stage 1. If you don't, you're stage 1. which reflects that the vast majority of patients with thyroid cancer are stage 1. They're less than 55. They don't have distant metastasis, and their risk of dying is very, very, very low. Now, on the other side, if they're older, obviously, if they have distant mets, that's a bad thing. And then the next big thing is gross extrathyroid extension. Once again, we've gone back to the 1970s. We knew in the 1970s the bad prognostic features for thyroid cancer: gross extrathyroid extension, distant metastasis, older age. We're right back to that same caveat, where if there's no gross extrathyroid extension, they're going to be stage 1 or stage 2 based on size and lymph nodes. If there is gross extrathyroid extension, then you need to know what was being invaded. If it's just the strap muscles, major structures, or unresectable. So this puts the onus on our surgical colleagues that say in your op report, you need to dictate for the endocrinologist so that we know what structure is involved. I know sometimes in the notes you guys imply what's going on, but I love to have a paragraph right above before you start that whole 3-page, 1-paragraph, dear your honor, here's what we did. A little paragraph at the top that says findings. Here's what we found. No gross extrathyroid extension, or it was invading a strap muscle and we resected that, or I scraped it off the trachea, because we need to know that to be able to do good staging. Now, there's many people that have published on this. This is from Dr. Shaha at our group. This is called an alluvial graph, and it just shows you on the 7th edition where were people, and on the 8th edition where were people. And so what you see is that in the 7th edition, there were hundreds of people in stage 4 and stage 3. But in the 8th edition, very few people stage 4, very few people stage 3, most people stage 1, and most people stage 2. Now, if you think about your thyroid cancer clinic, this 8th edition looks more what it's like. You don't have a third of your patients likely to die of thyroid cancer. We know that's not true. But there is a small group of patients, the stage 3s, that are going to do poorly, and the stage 4 that may die of disease. So this represents much more the distribution of thyroid cancer. And Julianne Souza's group looked at the SEER data, some 64,000 patients, classified them by 7th and 8th edition, and you can see that this system now works much better. Here's why the 7th edition didn't help me. Stage 1, stage 2, stage 3, it was all the same. The overall survival was the same. And it was only the stage 4 distant mets that did bad. And in fact, they didn't do all that bad because there were a lot of stage 4 patients in there that weren't going to do poorly. Now, look at what happens in the 8th edition. You now have a distribution, stage 1, stage 2, stage 3, stage 4, much smaller numbers in stage 4, much more up here in stage 1. It's not perfect, but it's certainly moving us in the right direction. Now, that was all done, I don't know, we wrote that in 2016, 2017. We knew there were some things that would need to be addressed. I'll show you some areas that we're working on. We're about to do the 9th edition now. That's just getting started. I don't know exactly what it'll be, but here's the areas that we're going to work on. Number 1, a classic papillary or a BRAF mutated tall cell that's only invading the strap muscles anteriorly. That's an easy one for the surgeons to treat, because when they pull the strap muscles, there's the tumor. They take out the tumor and the strap muscles. And now there are several publications that show that, in fact, should probably be stage 1. Yeah, there may be a little higher risk of recurrence, but these people probably, because we got a gross resection, don't need to be upstaged to stage 2. Likewise, if you have isolated invasion of a recurrent laryngeal nerve, for example, from a lymph node, that doesn't necessarily mean you're going to die and be stage 3. This got in there because most of the recurrent laryngeal nerve was involved because of gross invasion of the trachea and the esophagus and in the TE groove. So in that setting, it is a bad sign, but we'll probably pull out isolated recurrence of a recurrent laryngeal nerve with no gross extrathyroid extension, but only a lymph node involving that as separate. Likewise, we didn't deal with the size and the number of these lymph node metastases. So if you're more than 55 and you have any lymph node, no matter how microscopic, you get called stage 2. And clearly we know that's probably not correct. So we'll move some of those to stage 1. Now, the one thing that we probably won't change, but you need to be aware of, is that there are a few patients in stage 1 that are not going to do as well as you think. Now, think about this with me. A 54-year-old lady with gross invasion into the trachea, no distant metastasis yet, so she's a stage 1. But that doesn't feel right, because if you're 45 or 55 or maybe even 35 with a poorly differentiated tumor with gross invasion or unresectable disease, you know those patients are going to do more poorly. So when we looked at how we could address that, we said, look, in the less than 55 years old, here's our 2 stages, because you can't be 3 or 4 if you're less than 55. If you're a stage 1 patient, you can be low, intermediate, or high on the ATA risk stratification system that Jim showed you at the start of his talk. So the way we thought you could find these stage 1 patients that did poorly was maybe it's the stage 1s that have the ATA high risk. Could we use the ATA high risk as our flag? Yep, most patients with stage 1 are going to do great. And if you have 5,000 patients in stage 1, the 4 or 5 patients that do poorly, as a big group, you're still going to look great, but not so much for that individual patient. And so with Sana Ghaznavi, one of my thyroid cancer fellows at the time, she went through our tumor registry and we looked and just sort of said, what's the disease-specific survival? And in fact, in the stage 1, if you were low risk, it's 100%, intermediate risk, 98%. Here's the high risk patients, clearly a little bit worse. And then if you incorporate age, that's when you see they clearly do worse. So when you're thinking about these less than 55-year-old patients that are stage 1, you have to do AJC stage and you have to do ATA risk. When you call them ATA high risk, that's a flag to go back in and say, I don't have to memorize these numbers, but if you're stage 1 and ATA high risk, depending on your age, you may not do as well as the entire group of stage 1 patients. Now, as I mentioned when I started, for most of my patients, the issue is not whether they're going to die of thyroid cancer. The vast majority of patients are stage 1 or stage 2. We don't really anticipate many of them dying of thyroid cancer. On the other hand, we'll see a wide spectrum of risk of recurrence within stage 1 and within stage 2. So how did we get our handle around what's the ATA risk of recurrence? And this started all the way back in 2006 with Brian Haugen and I and several of the ones that were working on the ATA guidelines at that time. And we said, look, let's do this. Let's define a group of patients that are really low risk that nobody's going to argue about. Let's define a group of patients that are really high risk that nobody's going to argue about. And then let's put everybody else in the middle. And so that's what we did. So hardly anybody would argue that if you're a classic papillary confined to the thyroid, no invasion, no vascular invasion, if you gave radioactive iodine and there was no uptake, that would be low risk. Now, if you look, there's no age in there. There's actually no size. If you can find a 3-centimeter papillary confined to the thyroid with no lymph node metastasis, it's actually a low risk tumor. And look at the high risk. This is the same things that make you at high risk of death. Gross extrathyroid extension, incomplete tumor resection, distant metastasis, a TG that's too elevated. And then we put everything else in the middle. Now, it's important to know we put everything else in the intermediate, not necessarily because I thought they were intermediate. Some of them would be low, some of them would be higher, but to gain acceptance and to gain sort of consensus, it's easier to set the goalpost really good on each end, low risk and high risk, and then put everybody else in the middle. And then over the years begin to say, okay, we've accepted low risk, we've accepted high. Out of these intermediate risk patients, which ones are really closer to low and which ones are closer to high? And that led to this sort of a continuum of risk concept, that biology is not 3 boxes. It's not low and intermediate and high. The biology is there's a continuum of risk. Now, remember, these are the 2015 guidelines, so they were largely written 2013, 2014. At that time, we were getting the early indications of BRAF and TERT, and we see TERT mutated plus BRAF as one of the high. We see a range of where the BRAFs used to be. This is really early on in our understanding of BRAF and TERT and trying to understand how do those modify sort of the way we're thinking about these things. But even back then, you could see that we were using mutational status to modify and to be along this continuum of risk. Now, we've come a long way since then, and Dr. Nikki Foroff will be talking in the next talk about how, as we move forward, we integrate these molecular predictors into our clinical pathologic staging systems to help us further refine those. I wouldn't make the mistake of saying molecular biology is the only thing that produces risk factor, but it certainly can modify. It'll help me understand stage 1 or a stage 2 or intermediate risk to help me understand further what that risk of recurrence really is. And so that's ongoing. Now, one of the things that often comes up when I give this talk is people say, look, it's really easy for you to do risk stratification. You work at Memorial, you have Ronnie Gossain for your pathologist and Oscar Lin for your cytologist, and you've got all this immunotherapy. We've got all these things that we can do. But the question is, can we actually do AJC staging and ATA risk stratification without all these fancy pathology reports? Now, that was one of the topics that we dealt with. This is a brand new paper that was just published online last week, led by Dr. Gulick. This is the third of the collaborations between the American Thyroid Association, European Thyroid Association, European Association of Nuclear Medicine, and the Society of Nuclear Medicine and Molecular Imaging. This is always a fun group to have together. These are some of the largest egos on the planet. Mine was the biggest, so I got to go last. But very, very experienced clinicians that were looking at the same disease process through different lenses, both US and non-US, nuclear medicine, non-nuclear medicine, endocrinology, really a phenomenal group to work with and think through these issues. I don't have time to talk about the bottom two, but you'll find some good discussions in here. But we did look in this perioperative risk stratification about this exact same issue. How much detail do you need to do to be able to do AJCC and ATA? And I will tell you, you don't need fancy in-depth pathology reports to be able to do this, because just look at the variables you need to know. You basically just need to know which one of the cancers is it, because there's a different staging system for AJCC for differentiated anaplastic or medullary. The subtypes of DTC, you don't have to know. You don't actually have to know exactly how old the patient is, just more or less than 55. You don't have to actually know the exact tumor size, just more or less than 4 centimeters. You don't have to know the number or the size of lymph node metastasis or extranodal extension or the size of the, it's just yes or no. Is there gross extension? Is it what was invaded by the tumor? That's from the operative report. Same way with gross extrathyroid extension. Do they have distant metastasis? If you have just those factors, which doesn't seem like a lot, right? I mean, that's not an in-depth understanding of the tumor. That's just the factors from a clinical pathologic standpoint. You can do 8th edition AGC staging and get those outcomes that I was showing you. And likewise, for the basic ATA, the low, intermediate, and high, that have been showed to risk stratify patients in 30 or 40 different studies all over the world, this thing works. Again, you just need the basic histology, yes or no lymph node metastasis, yes or no gross extrathyroid extension, resection. These are all factors that are easy to do. And then from the theragnostic approach that we've been talking about, understanding how the biology implies whether radioactive iodine is going to be helpful or not, or the scan. Now, obviously, if you have the opportunity, you can further refine those risk estimates. And that's even when we wrote the 8th edition, there's several sections in there where we said, look, you can not only have to do exactly the 8th edition, you can further refine that. That if you know the age and the specific number of nodes, it doesn't change your stage 1, 2, 3, 4, but within that 1, 2, 3, 4, you can refine that. And the same way in the ATA risk, these usually refine the intermediates, although there are a few of them that'll take intermediate to high and intermediate to low. Not a lot, but a few. Now, I'll come back to this before I finish. And it's this concept that Jim mentioned to start with, this idea about adjuvant therapeutic decision-making. So Dr. Fagan showed us in the RAI adjuvant therapy setting that just because you could define somebody at increased risk of having a bad outcome, that certainly didn't mean a well-meaning adjuvant therapy was going to help. But that discussion goes beyond just adjuvant therapy. It goes along prophylactic neck dissection. Should we clean out some little lymph nodes that are often there in the neck? What's the degree of TSH suppressive therapy? Jim showed you in the molecular biology, some of these tumors don't express TSH receptor very well. Why are we making the TSH go away if they don't really have a very functional TSH receptor? What about the role for external beam radiation? Yeah, the surgeon scrapes stuff off the windpipe and he scrapes up off the esophagus. We know there's microscopic disease there. We know they're high risk of recurrence, but is there data, and I'll say in that particular case there usually is, would external beam radiation help or systemic therapy? So while I love risk assessment and why I find risk assessment sort of the hallmark of adjuvant therapy decision making, the way risk assessment alone helps me is that if it identifies patients at very, very low risk of recurrence or very low risk of dying, then there's probably not really an adjuvant therapy discussion. That those low risk patients are probably going to do fine, and it's unlikely that adjuvant therapy would help them. But the converse doesn't work. Just because you find somebody that's at high risk, whether that's defined on molecular biology or histology or clinical characteristics or post-op thyroid globulin or response to therapy, no matter how you define that, yes, we can define them as intermediate or high risk, but we need to take the second step and say, can we prove that additional outcomes have an impact on the outcomes of interest? Which patients does radioactive iodine make a difference on? Which patients does prophylactic neck dissection make a difference on? Which patients does TSH? Because now we're asking not only the risk stratification question, but now we're asking the response to therapy question. Can we make a difference in those outcomes? Oncology is littered with patients that are at high risk of recurrence and high risk of death, and yet additional therapy has only minor impact on that. So when we began to sort of think for an individual patient about whether or not we should do adjuvant therapy, which means the surgery is removed all gross disease we can find, there's no abnormalities that we can find. Adjuvant therapy is treating the risk of disease. You're at risk, you may be cured, I don't know, but you're at risk for disease. Should I consider an adjuvant therapy? We'd have to look at what are the either proven or expected outcomes of interest based on the molecular biology and their histology and their tumors. We have to affect what's the side effect profile. Somebody that has very low risk of a bad outcome and your treatment has a high side effect, that doesn't make any sense. The patients are going to say no. Patients that have a very high outcome and the treatment has a very low side effect may be more reasonable. And so what I find is we're trying to help the patients understand what's the risk, what's the impact of whatever I'm going to offer you, what's the side effect profile that we're going to offer you, and then you help me understand what your values and preferences are. We all have patients that say, look, I don't care about the side effect. I want you to do everything to treat this thyroid cancer. One of my old thyroid cancer nurses that was with me years ago, because we get to see all the exceptions, we get to see all the weird stuff. She said, even if she had a low risk thyroid cancer, she wanted a total thyroidectomy, radioactive iodine, probably external beam radiation, and at least a few doses of chemotherapy. That she wasn't serious, but what she was expressing was her entire values was minimizing the outcomes as best we can, wasn't worried about the side effect profile. And then I often see people on the other side, because I tend to have a minimalistic management approach, that they understand that radioactive iodine, for example, or total thyroidectomy or a prophylactic neck dissection may impact the outcomes a little bit, but they're significantly worried about the side effect, worried about radioactive iodine and radiation, no matter what I say, worried about hypoparathyroidism if we do both sides of the neck, worried about recurrent laryngeal nerve. They're trying to balance that, what's the benefit versus what's the risk. And so when we get in this adjuvant therapy discussion, I couldn't agree with Dr. Fagan anymore. It's not just based on post-op risk assessment. Sure, if they're low risk, it may let you out of the adjuvant therapy decision. But if they're intermediate or high, then we need to rationally explain to the patient what's the outcome of interest. I will tell you, I have this discussion every week with a 3-centimeter tall cell variant of papillary thyroid cancer, BRAF V600E positive, invasion outside the thyroid, lots of lymph node metastasis, that I know that patient is high risk. I know everybody in the country would give that patient radioactive iodine. And yet I have to explain to that patient, I doubt that radioactive iodine is going to make much difference here. Can't guarantee it, but there's a overwhelming odds that if I give you radioactive iodine, I'm not going to change the outcome. Now, many patients will still choose to take it, some won't, but that's where we are in terms of trying to define what those outcomes would be. So I'll finish with this with my last slide. So as we look at where we've come, the last piece to the puzzle is response to therapy, because the last 35 minutes, we have covered probably the first 6 weeks in the life of a thyroid cancer patient. They've had their thyroid nodule found. If they're inappropriate for watching, then they've had their surgery. We've done their risk stratification. And then now, how do we follow these patients over the next 20, 30, 40, 50 years, depending on how long we're going to practice till we retire? We follow them up based at each time they come back, defining what's their outcome. So the fellows walk in the room and they tell me this is a stage 1, ATA low risk, and today their response to therapy is excellent or incomplete. You'll see on the arrows in response to therapy and the arrows in the paradiagnostic are circles. So you can change that every time the patient comes back. And AJCC stage and ATA risk are static over time. So I think we've come to an exciting phase over the last sort of 20 years, where we're now talking about real-time risk stratification. We're talking about how we bring to bear the proper treatment to the right patient, trying to balance this risk versus benefit, and then having a safety net of response to therapy that allows us to change our mind and do additional more or less treatments over time. I think we're at a really exciting time that we have the framework here that now we can build in other molecular markers and immunohistochemical markers and other response to therapy markers that help us do better at selecting patients that are likely to respond to adjuvant therapy and for patients that don't need adjuvant therapy. Thanks very much.